Well, hi, welcome back to another week on the YouTube channel. We're talking about all things related to the patient population that I and Dr. Cutchins see. This week, we're talking about orthostatic intolerance and specifically POTS. I, as an internist, have patients who come to me saying, "Hey, I've got all these symptoms. I've been diagnosed by TikTok. I am in Facebook groups. I've had these lifelong struggles, and no one will give me a diagnosis." And so that's really what we wanted to talk about today: is how do you get a diagnosis of POTS? Why are doctors so resistant to treating it, making the diagnosis, and understanding what to do, and what you can do as a patient or a clinician, if you're listening, to get people started in the right direction. So, with that, I'll have you introduce yourself, and then we'll get started.
My name is Alexis Cutchins. I'm a cardiologist. I am opening a practice in New York City this fall. October 1st is the fingers crossed, hopeful start date. And I take care of patients with POTS primarily, and all the comorbidities that come along with POTS. So I'm happy to be here to talk to Kara about, what I see and what you all can do to get this diagnosis.
Yeah.
Which is not easy, I know.
Yeah, so let's just start with like a basic definition of orthostatic intolerance and then how POTS fits into that. Orthostatic, and good.
Yeah, so orthostatic intolerance is essentially you have orthostatic intolerance if you have symptoms in the upright position. So if you're sitting for a long period of time or standing for a long period of time and you develop symptoms from that, like dizziness, lightheadedness, heart racing, or brain fog, fatigue, just cognition issues, or any symptoms like pain in your back or pain in your pelvis or pain in your lower extremities. These are all forms of orthostatic intolerance. The key is that the symptoms come on when you're in the upright position, and then they resolve for the most part when you lie down or lie flat. So that's orthostatic intolerance. POTS is a subset of orthostatic intolerance. And specifically, when we diagnose someone with POTS, we're looking for a rise in the heart rate from lying down to standing of 30 beats per minute or more. And so essentially, when you normally sit up or stand, your heart rate will go up. That's naturally the normal process that our bodies use to compensate for a change in position, but usually not more than 10 beats per minute. And when you have POTS, your heart rate goes up by more than 30. The other caveat is that you don't have a shift down in your blood pressure. So if your blood pressure drops, then that's considered orthostatic hypotension, which is another form of orthostatic intolerance, but technically speaking, it's not POTS. So what we're looking for is that increase in heart rate when you go into the standing position for a POTS diagnosis.
Yeah, that's right. So it's not actually that challenging to make. There's a test called the NASA stand test, which basically you can do at home, and I'll put a link to a diagram for that. But in essence, you have a laying down blood pressure and heart rate, a sitting, and then a standing, and then you check your heart rate and blood pressure every minute for 10 minutes. And you can actually track those numbers and see, does your heart rate stay up for up to 10 minutes, over 30 beats per minute? And that helps give the diagnosis. So can you talk about,
Yeah, so just to clarify with that, some people have an increase in heart rate right initially, and then it kind of settles down. That's technically not POTS.
That's right.
What we're looking for is an increase in heart rate over time that
Correct.
becomes sustained.
Yeah.
Exactly. And so you can do this test. We usually recommend doing it first thing in the morning, and we recommend doing it off of medications. And you can do it multiple days in a row. You can repeat it. If you have a log of this test that you can bring into your physician, it's very helpful.
Yes.
So that they can see that you've been monitoring your blood pressure and your heart rate while lying down and while standing.
And when you say off medicines, you're not talking about all medicines like diabetes stuff. You're talking about specifically heart rate modulating medications.
I am, but there's nuances, right? Some people really have to take their medications every day. And so I don't really ask for a washout period. But with this test, if you can do it sort of first thing in the morning before you even take your daily medicines, then you get a little bit of a cleaner result. And that's especially if you're taking things that lower heart rate or expand blood volume or change, any kind of parameter that might be included in the test.
So why would someone go see a cardiologist? What is the cardiologist looking for that we want to rule out, make sure we're not missing something besides POTS? And what kind of tests might they suggest you do?
Yeah, so the other issue with POTS is that you can have an orthostatic tachycardia for other reasons, like anemia or iron deficiency, or if you have some electrolyte disturbance or abnormality, if your thyroid is not functioning properly, if you have issues with other hormonal nuances that may be causing these, symptoms. So It's first important to rule out other stuff that could be causing POTS-like symptoms. I can't tell you the number of patients that I've seen in my office for an evaluation for POTS, and they were just profoundly anemic. They were bleeding a lot from their monthly cycle, and we fixed that, and they were fine, So you want to rule out other things that could look like POTS. And then as a cardiologist, I want to make sure that patients don't have anything really bad. So I'm looking for arrhythmias. So I'll do like a Holter monitor or an event monitor to look for abnormal rhythms, things like ventricular tachycardia, atrial fibrillation, weird rhythm abnormalities, or conversely, low heart rates, like symptomatic bradycardia, pauses in the heart rhythm. Those are all, going to be addressed in a different way. I also look at the heart structurally to see if there's anything there that could be causing a person to feel lightheaded when they stand up or have a racing heart rate. We look at the aorta to make sure it's not enlarged. We look for valvular heart disease, and we look for things like hypertrophic cardiomyopathy. So we want to make sure that the echo is normal. And then sometimes I'll put patients on an exercise treadmill and just see if there's any ischemic change that occurs with exercise or with the upright position. And that lends us down a different path as well. So we don't want to just diagnose someone with POTS and miss something else that may be contributing or may be, important to address. So I think POTS can be managed very well in the primary care setting, personally. And I think that more primary care physicians, it would be helpful if more of them would order these 3 tests, the event monitor, the echo, maybe the exercise treadmill test, plus all the blood work. And once all of that's kind of taken into account and everything looks okay, then start treating patients for POTS. And, that's, I think, something that a lot of primary care providers could be doing.
Yeah. So let's just recap. So like if you're having symptoms like Alexis talked about in the beginning, dizziness on standing, rapid changes in heart rate. So you can do the NASA stand test at home. You can ask for specific labs to be done by your primary care physician. That's a complete blood count, a CBC, a ferritin, which is a total body iron storage, a comprehensive panel that looks at electrolytes, and a thyroid test. That's a very basic thing that any primary care physician could do. And then after that, your primary care doc, even without the help of a cardiologist, can order a 30-day event monitor, an echo, and a stress test. And if all that stuff is normal, especially if there's not a cardiologist around who understands POTS, like that's sufficient information to get you started with that. Does that sound fair?
And to give you a diagnosis of POTS.
Yeah, that's right.
That's as long as you're meeting those criteria on your stand test.
Perfect. So then people say, well, okay, well, no one will treat me. No one knows what to do. So there's some very basic things that don't even require medications. I'll let you talk about meds, but very basic things that can really help from symptomatic treatment of POTS. So often when people hear that they have a, quote, blood pressure problem, they think they should not eat more salt. There is no upper limit in the amount of salt that someone with POTS can eat. The average adult, we try to get them to 2 grams of sodium per day. Really, for my POTS patients, I'm pushing them 4 to 8 grams per day, like as much salt as you can get, especially in the form of electrolyte packets. You can salt anything that you add. There's salt tablets that you can take. But the purpose of the salt is to expand your blood volume, to fill up your blood vessels so there's enough blood getting up to your brain. Compressive devices externally that compress your legs. So compression socks, which are not so much fun in the hot summers of Atlanta, but they work beautifully. You can do compression socks up to your knees, thigh-high compression socks. There's even abdominal binders that some people will use to fully compress all the way up to their, midsection. So the blood is coming back to their heart. And then it's frankly a little annoying to patients when doctors say something like you should sleep more and rest more, but pacing yourself, I find, is hugely important for POTS patients, especially if they have other comorbidities, to really understand what your body's limits are and to be able to pace yourself throughout your day. And then lastly, understanding some of the triggers for POTS, especially heat. We're recording this in August in Atlanta. It's 1,000,000 degrees here, and all my POTS patients feel like they're dying.
Yeah.
So understanding triggers. We'll talk about mast cell disease in a separate topic, but treating your underlying mast cell disease, understanding the triggers that make your POTS not great, and mitigating those make a big difference. Did I miss anything?
Yeah, no, that's great. I would just comment. Oh shoot, I had a comment. No, I don't remember what it was.
Okay, I have a comment. We're gonna talk about volume of
It's gonna
fluid.
come back.
It'll come. But the volume of fluid too. So not pure water, because people who are drinking a gallon of water per day will often dilute out their electrolytes. So that's why electrolyte supplementation in water can be really helpful. People say, how much water should I be drinking? The answer is enough to make your urine clear. I mean, ballpark 80 ounces a day, although I do have some folks who need more than that in order to sustain their volume.
Yeah, we say 90 to 120 in my clinic, but I think using the rule of thumb that your urine's clear, you're hydrated. Yeah. So
I
think that's pretty good.
All right, cool.
Yeah.
Do you want to talk?
Oh, I was going to say the pacing thing.
Yeah.
Okay. So it's really important to pace. And what's even more important is to be able to exercise, which doesn't come quickly for patients with POTS. Oftentimes we need to get you on medications. We need to get you on a regimen of fluids and salt and all the things that Kara just mentioned. But ultimately, the more you exercise, the better you're going to feel with POTS. But this is a very slow and graduated process. And so pacing, to begin with, is very important to understand what your body can do in a day. And once you've figured out exactly what your body can do in a day and what your signals are, what your body tells you, it's time to stop, like I can't go do another thing, then you can start adding in a little bit of exercise, because you're going to know when you've done too much. And what I tell patients is, if you exercise and crash afterwards, or the next day, or even 2 days later, sometimes it's a delayed process, then you did too much exercise. So you want to be able to do small incremental increases in exercise that don't cause you to crash. And that's going to help you build up tolerance for doing more and more activity during the day, which ultimately is what we want for our patients. We want you to be functioning, at your baseline or at a normal level. We don't want you to have to hold back.
Yeah. There are physical therapists. If there's anyone who's listening now or on replay, please leave comments. But there are physical therapists who also specialize in POTS, and I think they understand this very well. There's all kinds of new modalities that they're doing. And interestingly, like some of the lower extremity work they're doing with dry needling and muscle compression literally is there to help stimulate the venous return of blood back. So there's all kinds of people who really do understand this in your communities. So.
Yeah, and I think physical therapy is an excellent tool. Sometimes it causes people to crash because the session is going to be an hour long, and that might be too much for you. So if you're not quite ready for physical therapy, it's okay. We can, you can work up in different ways. And I think you have to be mindful that it might make you feel worse. And so therefore you have to build yourself up before you can actually do full-time physical therapy. There are physical therapists who do online therapy, which would maybe less involved, and it's more kind of recommendations and gives you sort of a pattern of stuff that you could be doing, which is very helpful. So there are ways around it, but just be mindful that if you're driving somewhere, you're doing an hour of physical therapy, you're driving back, that's 2 hours worth of exertion for a patient with POTS, which might be too much in one setting.
Perfect. So let's talk about meds before we close out today. So can you talk about high level, like what is the purpose of medications and what are some of the examples of those families of meds?
Yeah. So I use medications to get patients to feel better so that they can do more in their day. A lot of patients are non-functional. I mean, they can't get out of bed. Every time they stand up, they pass out. These patients need something else in addition to the fluids that they're taking in and the compression that they're wearing to help lower their heart rate, help expand the blood volume, help perfuse the brain. So we use sort of a lot of different things. In my practice, I spend a lot of time treating mast cell activation syndrome, which we won't talk about, but that is a trigger for POTS. So getting that under control is important. And when you ask about medications specific to POTS, they're sort of different buckets. So you have the medications that will expand blood volume and increase your blood pressure. That's your fludrocortisone, your desmopressin, the ones that raise blood pressure, midodrine, droxidopa. So those will help raise blood pressure and in turn lower your heart rate. Then there are medications that lower your heart rate. So that's like the beta blockers, propranolol, nadolol, metoprolol, a lot of others. Those will help lower your heart rate. The calcium channel blockers, I use diltiazem a bunch in my practice, but also verapamil. Those will lower heart rate. And then there's ivabradine, or the funny channel blocker, that just lowers heart rate and doesn't have any effect on blood pressure. In addition to those, there are other medications like pyridostigmine. Pyridostigmine helps activate the parasympathetic nervous system. So if you have someone with a lot of constipation and sort of GI dysmotility, I use it a lot, and it helps lower heart rate and it helps increase fatigue. So that's a good option. There are more, but those are sort of the
Decrease fatigue.
decrease fatigue. Did I say increase fatigue?
Yeah.
Sorry.
Yeah, it'll make you more tired.
Pyridostigmine helps with your fatigue.
Yeah.
So those are sort of the staples that
Yeah.
I use.
Yeah. And so any cardiologist should be able to prescribe those medications, but a good primary care doc, especially folks who are familiar with this disease, it's very straightforward stuff. We've been using these medications for blood pressure control and other things for millions of years. So it should be within our wheelhouse to do that.
Yeah, I think some of them are scary just because there's some labs you need to follow, like the fludrocortisone. Sometimes potassium levels go up, or with the DDAVP, your sodium can come down.
Yeah.
But internists prescribe medications all the time that have, adverse issues with the blood work, right? And that we monitor blood values, and, it's not that hard.
Yeah.
It's really not that hard.
That's great. So thanks. So this should hopefully give you all some perspective on it's not a mystery to diagnose POTS. We need to rule out things like electrolyte abnormalities and iron deficiency and thyroid disease. We need to rule out cardiovascular complications. So that's why the cardiovascular testing is there. And then even without doctor's help, you can be able to get yourself started towards some symptomatic relief. And if you need medications, finding someone who understands how to prescribe those is it. Thanks so much for listening today. We appreciate it. And I'll see you next week.
Thanks so much.